featuring Dr. Tiaga Nadaraja, a renowned senior consultant pediatrician and adolescent medicine specialist. Today, I am Dr. Tanusha from MMA Kedah, will be your moderator. A bit about Dr. Tiaga. Dr. Tiaga brings a wealth of experience and expertise to today's discussion. As the head of Department of the Pediatrics at Hospital Sultanah Bahia and the State Consultant for Pediatric Services in Kedah, Dr. Tiaga has dedicated his career to advancing pediatric healthcare and adolescent medicine. His professional journey is marked by a series of notable achievements and contributions to the field, including his fellowship in adolescent medicine at the Centre of Adolescent Health, Royal Children's Hospital, Melbourne, Australia, and his Masters of Medicine in Pediatrics from University Science Malaysia. His efforts has been recognized through several awards, including the Outstanding Asian Pediatrician Award 2022 and the Malaysian Medical Association Outstanding Public and Health Services Award in 2021. Furthermore, his groundbreaking work in adolescent health has been featured in the esteemed journal The Lancet. Dr. Tiaga, dedicated to advancing pediatric healthcare, and his tireless advocacy for the well-being of children and adolescents make him an exemplary leader and educator in the field. Without further ado, I invite you to join in welcoming Dr. Tiaga as he shares his insights and experience on upper acute respiratory infections in children. Dr. Tiaga, the screen is yours.
Thank you. Thank you, Tanusha, for the kind introduction. And good evening to all those who have logged in to follow this particular CME. And thank you to MMA Kedah to have organized it, and also the National MMA to plan the platform for it. So I'm at the pleasure of discussing, or rather presenting, a common condition in pediatric age group, which is the upper acute respiratory infection in children. And I think as general practitioners, as medical officers in hospitals, health clinics, or even us as parents at home, we do come across our own children, grandchildren, nieces and nephews coming with this condition called upper respiratory acute respiratory infection. So what I'll do today, I'll just discuss what are the common upper acute respiratory infection in children, and briefly discuss about the common, the most important ones. So my outline of my talk is I'm going to touch a bit on common cold, which is the commonest of all, pharyngitis, croup or acute laryngotracheal bronchitis, epiglottitis, and also diphtheria. So before I go further, one need to understand that the airway is divided into upper and lower respiratory tract. Upper respiratory tract starts from the nasal cavity, pharynx, and also larynx. But whenever we discuss about upper respiratory infection, we usually include the middle ear, the infection of the ears. Lower respiratory tract, on the other end, is starts from the trachea, primary bronchus, and also lungs. This is for the purpose of our discussion today. And children's upper airway is slightly different as compared to adults, making them more prone for respiratory infections. So if you look at the diagram here, generally the child's face is a bit hypoplastic as compared to adults. So as such, their nostrils are smaller, the nasal cavity is much smaller and tighter. So whenever they get any respiratory infection involving nasal congestion, they find it difficult to breathe. To make it worse, generally up to the age of 4 months, children are obligate nose breathers, meaning that they generally do not know how to open their mouth and breathe. So if the nose is just slightly blocked, they tend to have respiratory distress. On the other hand, their tongue is also generally falls rather back onto the back of the mouth. The airway per se, if you look at the cricoid ring, is a bit anterior. The vocal cord is also more floppy, and including the epiglottis. And the shape of the epiglottis is slightly different in children. So all this contributes to the upper airway of children being slightly narrower than the adults. On top of that, I think I've already mentioned about children being the obligate nose breathers, yeah? And infants and those less than 1 year old, also young children, they tend to rely mainly on the diaphragm to breathe as compared to the adults. So these are the major differences between the children and adults. And the common respiratory signs or respiratory distress signs in children are they tend to gasp for air, they speak in very short sentences. As compared to adults, whenever they have respiratory distress, they tend to have tachypnea. They breathe much faster than normal. The respiratory rate is much higher. Whereas in children, it can be both ways, meaning whenever they are in respiratory distress due to some form of infection, their heart rate can be high. Let's say for infants, can be more than 60, or the respiratory effort can be suppressed. We commonly see this in pertussis. Very often when they get pertussis, sometimes they present to you with apnea rather than tachypnea. And children, it's the same thing. They can be shallow breathing or tachypneic. They tend to have nasal flaring, intercostal, supraclavicular, subcostal retractions. Sometimes with a significant airway obstruction, upper airway obstruction, they tend to get gastridor or sometimes grunting. And if it's severe enough, they will present to you with cyanosis. And if there's hypoxia is significant with CO2 retention, they tend to get altered sensorium. So these are the main respiratory signs, distress signs in children. So when we talk about upper acute respiratory infection, we are generally, as I mentioned earlier, we're talking about nose, throat, ears, and also the sinuses. And one of the common organism causing infection is virals, and it is what is we call as common cold. So going straight to common cold, it's basically an acute viral infection manifesting with rhinorrhea or nasal obstruction. In bigger children, you may have sneezing, feeling very lethargic or malaise, and possibly some element of low-grade fever. Usually it lasts for about 3 to 5 days. Occasionally it can go on to 10 to 14 days. Some of them may have mild headache. And be alert that if they have significant headache, photophobia, or some form of rash over the skin, you need to think about meningitis rather than just a common cold. And sometimes they may have very high-grade fever, indicating that they may have secondary bacterial infection, including extension to the lower airway causing pneumonia. So generally, viral infection or viruses are seasonal, okay? And if you look at young children, they tend to get about 6 to 8 times per year, common cold per year. Adolescents, about 4 to 5 times per year. Common organisms are rhinovirus, parainfluenza. Although they peak around September to October, sometimes it can appear throughout the year. More commonly, we see adenovirus persisting throughout the year. Coronavirus and respiratory syncytial virus tend to be more common during winter months, similar to influenza A. There are more than 200 types of human rhinoviruses, and 50% of common cold in adults and children are caused by rhinoviruses. And of course, in younger children, the other viruses commonly causing common cold is respiratory syncytial virus, metapneumovirus, parainfluenza, adenovirus, influenza, and also coronaviruses. In the past few years, we tend to see quite a bit of adenovirus coming in with initially mild symptoms and then extending into lower respiratory infection causing severe necrotizing pneumonias. How do they spread from one person to the other? It can be through direct hand contact. The reason why we insist that doctors or healthcare providers must routinely use their hand rub to clean their hands before they touch patient and also after touching patients. It can be through inhalation of small particles, which is airborne after the child coughs, or deposition of the larger particles when it's expelled during sneezing and lands on the other person's nasal cavity or the conjunctival mucosa. If you look at the larger particles, if a person coughs, it tends to reach only about 3 feet. Slightly smaller particles to be more than 3 to 5 feet. And those who are infectious droplets, very tiny droplets, they can spread on to more than 5 feet. So here I have to emphasize again, the hand washing is extremely important, especially among the viruses which affects the children. Studies have clearly shown the rhinovirus and respiratory syncytial virus spreads by direct contact as compared to influenza and coronavirus, which is more of a small particle aerosol transmission. How do they present? Generally, rhinovirus and coronavirus have got these mild symptoms of rhinorrhea, congestion of the nose, sore throat as secondary symptoms. Adenovirus, you tend to see, if you see a child coming with common flu symptoms, on top of that, they have a conjunctivitis or some form of exudative pharyngitis, then you should think about adenovirus. Influenza, as most of us know that when we get influenza infection, we tend to have significant myalgia and fever. Do we have to do specific laboratory investigation to confirm this infection? Generally, it is not helpful because we know these are the common viruses and self-limiting. So generally, it's not recommended. And certainly, radio imaging is not recommended unless we find some clinical finding in the lungs, which could indicate that there's a secondary infection or extension of the viral infection to the lower airway. Management is generally supportive and some form of anticipatory guidance to the parents. So antiviral, some of us will think that why don't we give antivirals? Because we have got a few antivirals available. But generally, it's not available for rhinovirus. We may try ribavirin, which is approved for severe respiratory syncytial viral infection. When I say severe, it refers to severe enough to cause the lower respiratory infection. The other commonly used antivirus, oseltamivir or zanamivir, which is used for influenza virus. Okay, now this is a dose for oseltamivir for children. Yeah, so we do give oseltamivir fairly frequently if they come in with significant respiratory symptoms, especially lower respiratory symptoms, which is suggestive of virus. Because as you remember that in recent months we had quite a bit of outbreak of influenza virus. Yeah. Okay. The other supportive care is basically good hydration. If the child can take well orally, oral rehydration should be enough. Sometimes we may give topical nasal saline drops to remove the secretion. Occasionally, we can do saline irrigation. Otherwise, the other antihistamine, antitussive generally not recommended for children. Decongestion generally not known to work very well. But I think most of you will agree that especially those who are practicing in the private sector, general practitioners, it's very difficult to tell the parents that, you don't need to take anything, you just go home and continue with your supportive care. It's a bit tricky. Occasionally, some form of decongestion may help them to dilute the secretion so that it's easy for removal. Certainly, antitussive is not recommended. In some patients, sometimes the severe cough can cause viral-induced reactive airway disease. This is what we call as viral-induced wheeze. Okay, so we keep that in mind that sometimes they can really cough significantly to cause wheezing. Some people say that, using camphor, menthol, eucalyptus oil, or some may relieve nocturnal cough. But generally, studies done in children shows very limited effectiveness. What are the ineffective treatments proven by studies? Vitamin C doesn't really work. Humidified air generally not very useful. And there's no evidence that we need to give antibiotics unless the patient a prolonged common cold symptoms leading to sometimes persistent purulent rhinitis. Then you may think that there's secondary infection and may benefit from giving antibiotics. So generally, if you look at the common cold, most of it is supportive, but do look out for the possible complications, such as acute otitis media. Sometimes they may get extension into the sinuses, cause sinusitis, and not uncommon to see them having some exacerbation of asthma in such children. Prevention, generally chemoprophylaxis or immunoprophylaxis, generally is not available for common cold. The take-home message is common cold is a self-limited condition, which presents with nasal congestion and discharge, sore throat, cough, malaise, and fever. Diagnosis is usually apparent from the clinical history and physical examination. Laboratory studies are not necessary. Treatment of acute upper respiratory infection is aimed at alleviating the severity and duration of symptoms. Antibacterial agents or antibiotics are not effective. Let me now move on to acute pharyngitis, which is another very common condition we encounter among children. Pharyngitis, we know this is the structure of the pharynx at the back. And what are the common organisms or agents, infectious agents causing pharyngitis? Again, if you notice, majority, easily about 70 to 80% of pharyngitis is caused by viruses. The reason why we generally do not recommend antibiotics for acute pharyngitis unless there are signs and findings in the throat which indicates that it could be bacteria. And the common bacteria are Streptococcus, group A Streptococcus, and occasionally, these are the commonest, sometimes we do Mycoplasma pneumonia too. So it's basically pharyngitis refers to inflammation of the pharynx, including some erythema, edema, and exudates, which may see plus the redness inside, or we call it anantum. Most commonly, as I mentioned, is due to viral infection. Most frequently occurs those who are just preschoolers and also up to adolescents. And it's very uncommon among young children. So I notice even among my doctors, they very commonly, the moment they see the throat is red, they diagnose as acute pharyngitis. Sometimes they even diagnose as acute tonsillitis. We must remember that tonsils are not very well formed in the children up to even 2 years old. So when the tonsil is not very well formed, you can't actually get tonsillitis. Yeah. So it generally has got very gradual onset, characterized by malaise, fever, and mild sore throat. Rhinorrhea, hoarseness, and cough and conjunctival diarrhea may also occur. So children tend to have diarrhea. This is what we call as parenteral diarrhea, meaning when there's an infection outside your gastrointestinal system, the body can react and cause diarrhea. And this diarrhea is usually not very severe, very mild, usually frequent, small amount of semi-solid stool. On the other hand, acute bacterial pharyngitis is commonly caused by group A beta hemolytic streptococcus, almost 15% of it, and it tends to come with very sudden onset of high fever, with tonsillar exudates, petechiae on the tonsils or the roof of the mouth, significant sore throat, swollen lymph nodes, and headache. So these are the cardinal symptoms of acute pharyngitis. It's usually typical cough and rhinorrhea, as I mentioned earlier, and the gold standard is still throat swab, throat culture. So if you suspect bacterial pharyngitis, it's good to do a throat culture just to find out which bacteria it is, and so that you can treat it appropriately. Most untreated streptococcal pharyngitis resolve within 5 days, even without treatment. However, if the findings are very significant, one would rather treat the patient to prevent acute rheumatic fever. Okay, so if you see very significant redness and so on, so you would rather treat the patient, especially if they've got significant exudates. Yeah. So otherwise, provide symptomatic pain relief. Antibiotic can be used, as I mentioned earlier. So let's move on to something more worrying or rather difficult to differentiate sometimes with more serious condition like epiglottitis, what we call as acute laryngotracheobronchitis or croup. It's one of the most common cause of infective upper airway obstruction. Here I'm talking about obstruction, yeah, not just infection in pediatric age group. Generally seen among 18 to 24 months, like 1.5 to 2 years old. Commonest organism is parainfluenza virus. Other viruses can also cause this, respiratory syncytial virus, rhinovirus, and the other viruses I mentioned earlier. Herpes viruses and influenza virus tend to cause more severe disease as compared to parainfluenza virus. So if you notice the upper airway obstruction and lower airway obstruction. Upper airway obstruction tend to cause stridor as compared to lower airway obstruction, which tend to cause wheezing or rhonchi. The reason being the upper airway is exposed to your atmospheric pressure. So when you breathe in, when there's a negative pressure developed in the pleural cavity, the upper airway, the atmospheric pressure is slightly higher than your intrathoracic pressure. As such, there's a pressure from outside causing the narrowing of the airway. Whereas intrathoracic, during inspiration, there's no the post atmospheric pressure is much higher compared to the negative pressure in the intrathoracic cage. But during expiration, the intrathoracic cage pressure improves or increases, causing more narrowing during expiration. That is why lower airway becomes narrower during expiration, whereas upper airway becomes more narrow during inspiration. The reason why we get, say, in acute laryngeal tracheobronchitis, you tend to get inspiratory stridor. Doesn't mean that you cannot get expiratory stridor, but very commonly it's inspiratory stridor. Now, this is just a table comparing croup or laryngotracheal bronchitis, epiglottitis, bacterial tracheitis, diphtheria, and litropharyngeal abscesses. These are the conditions you must think of when a child presents with stridor. Besides a sudden onset due to foreign body inhalation. Yeah. So here today I'll just focus on viral croup and epiglottitis, which, as I mentioned, is croup is caused by parainfluenza, whereas epiglottitis is due to Haemophilus influenza. Later, I'll describe the major differences. Yeah, it's very important to differentiate croup and epiglottitis because one is acute emergency, one is relatively benign condition. So how do we treat acute laryngotracheal bronchitis? Supportive care again, rehydration, antipyretic if they got fever, humidified inhalation helpful. We do give corticosteroids, often dexamethasone. You can give it intravenous, you can even give it intramuscular those days. And some severe ones, we can give nebulized adrenaline. On the other hand, epiglottitis is the inflammation and the cellulitis of the soft tissue above the vocal cord and glottis, meaning that it can affect the epiglottis, vallicular, arytenoid cartilage, and also epiglottic fold. And this can cause severe life-threatening obstruction. Symptoms include almost similar like croup, which is hoarseness of voice, severe sore throat. They may appear very anxious, significant respiratory distress, and drooling of the saliva because they cannot swallow the saliva. So here I put in a table form to differentiate epiglottitis and croup. Children coming with epiglottitis, they look very unwell, toxic looking, whereas croup, generally they look fine. Onset of epiglottitis is rather sudden as compared to croup. Fever is much higher in epiglottitis because remember, epiglottitis is due to bacteria, which I'll explain later. Stridor is usually moderate to severe, whereas in croup, it is usually mild to moderate. Cough generally is absent in epiglottitis compared to croup. And in epiglottitis, they usually can't speak at all. And they cannot swallow their secretion. They tend to have drooling of saliva. So if you look at what happens to the epiglottis, is that it will appear like a very red, cherry red, very edematous. And you don't actually look into the throat when you suspect epiglottitis. You must prepare all your resuscitation trolley, get someone standby, especially the ORL surgeons, ENT surgeons to stand by, even anesthetists, in case patient goes into sudden spasm and collapses, you may have to do a emergency tracheostomy. Okay. Those children who do not receive vaccination of Haemophilus influenza vaccination, they had higher risk. Fortunately, for the past 20 plus years, our Ministry of Health has started giving, included the Haemophilus influenza vaccination as a routine vaccination in the National Immunization Program. Since then, I rarely see epiglottitis. Commonly affects children between 2 to 7 years. And as already mentioned, Haemophilus influenza is the main cause, almost 99%. Others can also cause epiglottitis, the beta hemolytic streptococcus, occasionally the viruses, and even Klebsiella and even fungus. Now, I already mentioned about what happens due to the infection. Sometimes, although generally looks very red, occasionally it can look a bit pale if it is caused by streptococcus. And if the supraglottic edema is severe, it will cause complete obstruction of the upper airway. Right? So often, as I already mentioned, short history, severe symptoms, and severe stridor, and they look very toxic. And it is classic tripod position. I'll show a picture afterwards. This is how epiglottis, edematous epiglottis due to epiglottitis look like. And this is how a child with epiglottis will appear. This is what we call a tripod sign. The child leans forward, extends the neck to open up the airway and breathes. This is because due to the severe inflammation, it literally closes the airway completely. Right? It floppy closes. This is what it is, a normal airway, larynx. This is okay. Can you imagine the tiny slit? How do we intubate these patients? Difficult. So management is basically secure the airway, and you need to start antibiotic. Often is third generation cephalosporin in the form of ceftriaxone. Generally, we use ceftriaxone. Now, we have discussed about epiglottitis. Let's look at diphtheria, which we had this unfortunate opportunity to see quite a number of them pre-COVID when we had outbreak of diphtheria among a group of children who are not vaccinated in Kedah. This is what I'm showing is actually pseudomembrane. Yeah, it's caused by a Corynebacterium diphtheria commonly. It's mainly it's a very toxigenic strains which one causes it. Occasionally, Corynebacterium ulcerans can also cause diphtheria. Acute phase generally involves tonsil, pharynx, larynx, and nose. Mild, no membrane formation. When severe, they tend to form membrane, patches of grayish white membrane surrounded by inflammation. The toxin causes local tissue destruction at the site of membrane formation and promotes multiplication and transmission of the bacteria. So most of the multiplication occurs in the throat and subsequently gets spread. Incubation is pretty short, between 1 to 6 days. Very insidious onset, typically within 3 to 4 days of upper respiratory infection, fever, sore throat, lymphadenopathy. Then they get this bull neck appearance. And when you look at the throat, you'll see the membrane as I mentioned earlier. And if you try to remove the membrane, because it's a form of pseudomembrane, when you remove it, it bleeds underneath. They can cause secondary pneumonia. The patient I mentioned earlier had secondary pneumonia. Those are admitted to us in pre-COVID period. They had pneumonia. But sometimes the toxin-mediated disease can occur, including myocarditis. They can develop myocarditis, cardiomyopathy, neuritis, and even adrenal failure with severe hypotension. How do you manage? You must still give diphtheria antitoxin without waiting for the lab confirmation if you suspect diphtheria. Antibiotic alone is not sufficient, so you still must give the antitoxin. Treatment, we give penicillin or erythromycin for 2 weeks. During the convalescent period, you vaccinate them. We must give antibiotic prophylaxis in the form of penicillin and erythromycin for close contacts. And those who have not received the immunization, you must immunize them with the multiple doses. So generally, in summary, upper respiratory infection is common in children, often caused by virus. However, high index of suspicion is required in case of diphtheria and epiglottitis. As we still have some time, I'm going to share some of the real cases we had which has caused upper respiratory infection in children. Case number 1 is an 11-month-old male, youngest of 13 siblings, unvaccinated, was referred from a nearby hospital for ventilatory support. He presented with 1-day history of fever, cough, and rapid breathing. And the child also was less active with poor oral intake at home. So he had a history of ill contact with his elder sibling with similar symptoms, who was also intubated and treated as septicemic shock secondary to diphtheria. And unfortunately, he died. So these were the findings. So he comes from a very poor socio-economic background, not even a birth certificate. Father is an active intravenous drug user. So during intubation, this child came in very ill, so we had to intubate the child. It was noted he had a very whitish lesion over the pharynx, vocal cord, and epiglottitis. The vocal cord appeared very erythematous. He was ventilated for 2 weeks and transferred back to the referring hospital. From there, he was sent home a week later. This was his actual picture of the patient. So edematous, great, some whitish patch. This is what we remove, all these pseudomembranes, yeah? Chest X-ray showed some secondary infection, pneumonia. So throat swab grew Corynebacterium diphtheria. Unfortunately, after he was discharged from the referring hospital, he was discharged to the nearby the referring hospital, continued treatment there, and discharged home well. 5 days later, he had sudden collapse. We believe this is not something new, because those days when I started my career as a medical officer, we used to see this. They recover, fine, few days later they collapse. Remember what I mentioned about myocarditis? So this patient most likely had myocarditis post diphtheria. So it's unfortunate, yeah? So this I've already explained earlier. It's a serious vaccine preventable disease. That is why we must advocate for immunization for all children. Okay, so I'd like to show what happens. Myocarditis can occur in the second week, as happened to this particular child, can lead to arrhythmia and sudden death. I have seen during my MO-ship diphtheria causing palsy, facial palsy. I have seen patient going to renal complications. So definitely I've seen one or two myocarditis, patient starting collapsing at home. So it's a serious thing, yeah. So we need to vaccinate all the children. This is an older immunization schedule. So I think here we have not added in the pneumococcal, yeah. So case number 2, a 9-year-old schoolboy presented with lethargy for 3 weeks and breathlessness for 3 days. He had migratory joint pain and orthopnea and palpitation, loss of weight of almost 10 kilo in 10 months, a low-grade fever for 1 month. He did not have fever at that time. He was tachycardic. Blood pressure was acceptable. He was slightly tachypneic. He did not look septic. When we examined the cardiovascular system, his blood pulse volume was good. However, he had pan-solid murmur of the mitral area, radiating to the axilla, and lungs showed revealed by basal crepitations. He had hepatomegaly of 4 centimeter. However, spleen was not palpable. His total white was normal, hemoglobin was lowish. His ASOT titer, anti-Streptococcus titer, was very high, 1,600. ECG showed prolonged PR interval, some element of left ventricular hypertrophy. Chest X-ray revealed cardiomegaly and pulmonary congestion with infiltrates. At that moment, our impression was this patient is having acute rheumatic fever. So you may wonder, why was he losing weight for the past 10 years? So he probably had an episode of acute rheumatic fever some time ago. He sort of recovered on his own, and now he's coming with a new episode of acute rheumatic fever. Yeah. So it can go on for some time. It's not uncommon that we see them coming. They don't present on the first time because they assume that it's just one of those fever and they recover. So they assume that it's just some form of sore throat or some form of pharyngitis, and patient is self-recovery. But often it could be acute fever, acute rheumatic fever, which has sort of settled down, and then they come again later, after months later. So we treated him with IV furosemide, C-penicillin, and started him with oral penicillin in view of the carditis. So this was his X-ray, slight cardiomegaly with lung infiltrations and lung congestions. Echocardiography was done on day 4 admission, showed dilated left atrium, left ventricle, thickened left atrium and left ventricle, mitral regurgitation. However, there was no aortic regurgitation. With treatment, the erythrocyte sedimation rate, or ESR, gradually dropped from 82 to 13. The prednisolone dose was started initially, tapered down, and subsequently started on aspirin. Repeated echocardiography on day 30 of admission shows severe mitral regurgitation. Prior to discharge, he was well, except for the pan-solid murmur over the mitral area. His failure was in good control, and we discharged him on regular IM benzyl penicillin as a prophylaxis. Okay, latest we review later. Subsequently, he was doing fine except for the mitral regurgitation. Okay, so as you all know that these are the major and major criteria for acute rheumatic fever, carditis, polyarthritis, erythema marginatum, subcutaneous nodule, and ciliary scoria. And the minor criteria are fever, polyarthralgia, and the laboratory investigation, and with a positive culture for group A streptococcus or at least a ASV titer. These are the duration of prophylaxis. Generally, we give those who have carditis, acute rheumatic fever carditis, we continue the prophylaxis penicillin for 10 years or until 40 years, whichever is longer. Those with no residual heart disease up to 21 years or 10 years. Those without carditis, just 5 years or until 21 years. So this, you can always Google the standard guideline for management of acute rheumatic fever and the subsequent prophylaxis. And I think this is the last case, or case 3. An 8-month-old male infant appearing very malnourished, 8-month-old, only 3.48 kilo, admitted with fever and cough, landed in emergency department in moderate respiratory distress. Initially was stable on nasal prong oxygen. He was on IV cefuroxime, being treated as pneumonia. But though day 3 deteriorated, requiring intubation, and the antibiotic was escalated to cefepime and amikacin, as there was some suspicion of aspiration. The reason I mentioned aspiration is because we gave a gram-negative coverage with amikacin, yeah? This was his X-ray, very bad X-ray. One look at it, you tend to think that it could be virus. He developed pleural effusion. He continued to deteriorate, and unfortunately, he passed away with multi-organ failure. And the nasopharyngeal aspirate detected adenovirus. So why I'm describing this particular case is that one, the child is already a risk factor because the child is severely malnourished. We know malnourished children are prone for infection. Two, adenovirus is a very nasty virus among many of the other viruses. In children, it causes very severe pneumonia, often with necrotizing pneumonia with chronic lung disease. With that, I'd like to thank all of you for listening, and I'm happy to take any questions. Thank you.
Thank you, Doctor, for the very uh, educational talk. There are so far we received 8 questions online. So I'll read the questions one by one, Doctor.
Sure.
The first question is, when will you consider a chest X-ray for a child presented with URTI symptoms?
Okay, a good question, because as I was alluding to you all earlier, sometimes we always have this fear that when the child is having so much of symptoms of cough and flu, whether there is any low respiratory infection. So generally, we do not do X-ray just for rhinorrhea or low-grade fever. We look for signs of low respiratory infection. If there's no signs to suggest low respiratory infection, then I wouldn't do chest X-ray.
Okay, I hope that answers the question, Doctor. All right, the second question is, in ED, usually we don't provide antivirals for common colds. What is your take about this?
Okay, if you're treating, as I mentioned earlier, if you're treating common cold, you do not need antiviral. But if you think that this patient is probably having influenza, especially in the situation where there's an outbreak of influenza, you may want to give. But in this situation, usually they come a bit more ill and may require admission. So much so that most of the time, if they've got influenza infection coming to hospital, very often they are a bit unwell enough to require admission. And once they're admitted and we suspect influenza, we do give them oseltamivir. So ED don't routinely, we do not want to over prescribe oseltamivir, which we have at the moment. So we have to be careful. Say, just a common cold, the child is very well, otherwise feeding well, then I wouldn't give them, commonly, I wouldn't prescribe oseltamivir as outpatient.
So unless, Doctor, when the child comes in very ill, then we
Correct.
do prescribe
We
antivirals
do.
upon admission, right?
Yep. After assessing the child.
Okay, all right. Thank you, Doctor. The next question is, does saline nebulizer help with the URTI symptoms and also suctioning to remove nasal secretions?
Okay, here I'm talking about my personal experience rather than statistics and data and research. So I do see, generally when we give saline nebulization, it helps the child. So I do prescribe saline nebulizer in children who got significant nasal congestion. So it sort of, salines tend to soften the secretions and also make it easier for the child to bring it out. So I do give, but not as a routine. Just mild rhinorrhea, I wouldn't give. If a significant nasal congestion with blockage, I do give them. And suctioning has to be very gentle suctioning, yeah? Not very deep suction, because deep suction or repeated suctioning may actually cause irritation of the nasal cavity and causes more secretion because of the inflammation from the suctioning rather than the actual disease. Gentle suctioning be enough, if at all required.
We have another few more questions, Doctor. We still have time. So the next question is, Doctor, could you please advise on how to properly do nasal saline irrigation for children with common cold?
Okay, I need to confess here that I've got no experience doing nasal saline irrigation. I was just quoting as what people do in some places, but generally I've not done it. So I really have no experience doing it.
Okay, Doctor. The next question is, I think
Same,
uh,
yeah?
the same question
Yeah.
about nebulized saline and nasopharyngeal
Okay,
section. I
chest
think
physio. Okay.
chest physio and
Okay.
nasal
Chest
aspiration.
physio generally not recommended for upper respiratory infection, not recommended. And
Okay,
nasal aspiration, as I mentioned earlier, gentle suctioning suffice.
okay, all right. The next question is, if tonsils swollen grade 3 but not really erythematous or exudate, should we cover with antibiotics?
Okay, very good question, because we must remember the children, young children, especially those about less than 3 or 4 years old, their tonsil naturally is larger than adults. So not all enlarged tonsils or not all big looking, large looking tonsils are infective. So if they are not inflamed, I wouldn't treat them with antibiotics.
So usually mostly enlarged tonsils erythematous is
Then even though if erythematous can also be virus, but if I look at it, if they get significant exudate, then I'm a bit concerned whether it could be bacteria and I'll give antibiotic. Just mild redness with enlarged tonsil, I usually don't give the antibiotic because I also rely on the way the patient presented to you. Significant rhinorrhea, significant uh, common cold symptoms, and with mild redness and enlarged tonsils, I will treat as virus.
Doctor, it's my personal question. Do we like advise parents, because when there is erythematous tonsils, child doesn't tend to eat much, reduce oral intake. Do we like, how to say, advise parents while when the child is not well, having erythematous enlarged tonsils, to give ice cream?
Okay, okay, interesting. So the reason why it's not the ice cream per se, even yogurt. So basically, when the throat is inflamed, anything cold is very soothing and they can swallow. So I do routinely tell them if your child can take ice cream, those we are scooping, not the stick ice cream. So I tell them if your child can take at least that, give it no harm because it's a bit more soothing. So it does help to increase a bit of their calorie. But that alone won't be enough. They still have to take other meals like soft diet and so on.
Will cold beverage or ice cream increase sputum or the phlegm production, doctor?
No, no. Generally, no, unless they have underlying viral induced wheeze or some allergy phenomena or atopy, then it may trigger. But otherwise, generally, healthy children with no other atopy, they usually do fine.
Okay.
Generally, elderly people last time they used to say ice is no good for fever. It's actually good.
True. Okay. Thank you, doctor. The next question is, how do you differentiate parenteral diarrhea with AGE?
Okay.
Treatment wise, just ORS, I
All right.
suppose.
Excellent question. Because this is what I routinely tell my doctors that acute gastroenteritis, they tend to have large amount of watery stool and may not be as frequent. Or put it this way, lah. Usually acute gastroenteritis, the initial presentation will be large amount of diarrheal stool. Whereas parenteral diarrhea, almost always, there are diarrhea very, very frequent, small amount. Very frequent, but small amount. Sometimes more frequent than the actual acute gastroenteritis, but very small amount. You ask, macam, we ask the parents, bila anak berak tu macam dia sekaligus banyak keluar ataupun dia keluar kerap tapi sedikit. Almost 99% of the time, or if it is parenteral diarrhea, they'll say that, oh memang dia keluar sikit, sikit-sikit tapi kerap. So that's how the major difference lah between. Of course, other history of acute gastroenteritis, you know that, they've got certain meals they have taken outside and so on will also assist you. But a patient coming with upper respiratory infection and having diarrhea, the diarrhea tend to be small, frequent.
I think just to add on, doctor, maybe the history taking in this part is very much important
Very
to
crucial.
differentiate, especially food intake, water, sanitation, right, doctor?
Yes.
All right. The next question, doctor. What is your opinion regarding phlegm suction procedure? Is it
Okay.
an effective, helpful procedure? I think we have covered that.
I think, yeah, basically we're talking about suction from the nose.
Okay. Next question, doctor. Is croup and you upper respiratory infection or lower respiratory infection?
Okay. Very good question. You see, generally, if you go by the anatomical lesson we have, anything above vocal cord is upper airway. Below the vocal cord is lower airway, right? So technically, when it's acute laryngotracheobronchitis, generally you can say that it's actually also partly lower respiratory tract, right? Now, but when it comes to WHO, although anatomically is vocal cord above is upper, vocal cord below is lower, but WHO tend to, because remember upper airway, general principle, upper airway is not dangerous. But we know that epiglottitis or epiglottis sits in the upper airway. And we know it's extremely dangerous condition. So for that purpose, WHO puts epiglottitis as a upper airway. But the question is it upper croup? Is it upper or lower? It's a mix of both. It's a mix of both. But because of the manifestation is usually very mild, we tend to categorize it under the upper airway for clinical purposes.
Next question, doctor. When is it rheumatic heart disease need to refer CTC for valve repair?
Very good question. So when do we refer those with chronic rheumatic valvular heart disease to the cardiothoracic surgeons for repair? So what happens is that, like for example, that particular child, if the mitral regurgitation remain very severe on follow-up, despite the good control of the heart failure, and it is not responding to our maximum of anti-failure, then we will usually refer for replacement. More so if it is an aortic valve involvement. Aortic valve involvement can cause severe heart failure. So aortic valve we tend to refer early. The rest is usually refer when the heart failure is not very well controlled. Okay, often it's decided by the cardiologist when we refer to cardiologists. Hope that answers your question.
Next question, doctor. Why we remove the pseudomembrane in the first case?
Remember during my presentation, I mentioned that the membrane becomes it causes inflammation. Basically, it's a dead tissue. The bacteria multiplies in the throat. It multiplies, so it becomes a culture medium for the medium for the Corynebacterium diphtheria. So that is the reason why we remove it.
Next question, doctor. What home advice should we give parents, especially for those who are anxious? There is tendency for parents to get OTC decongestion drops or sprays.
Certainly, any parents, if the child is having cough and flu, a bit of fever, become very cranky. Here we are talking about very young kids, yeah. So parents will obviously be anxious, and here they come and see, say in the hospital, we say we don't need anything, it will resolve by itself. It's very difficult for parents to accept. So that is why when some of my fellow colleagues sort of sometimes criticizes the private practitioners for giving medication, I always tell them, how easy is it for you to tell the parents who come to you with a child with these symptoms and tell them, don't worry, everything will be okay on its own, and give them nothing. So it's not easy. It's not easy to practice that kind of thing. So what I would recommend is that generally give something the mildest form of decongestion, mildest form, and at least you sort of placebo effect for the parents. So generally, so rather than them buying over the counter, sometimes I tell the might as well just give it. You know what you're giving. Over the counter, it can be sometimes they overdose. Parents overdose. Sometimes I notice, general practitioner gives the say antihistamine, even antihistamine for some bigger patients. They would say they don't take twice a day or 3 times a day. Some parents overdose the antihistamine or decongestion. So I would basically advise the parents as much as possible. Otherwise, give the mildest form of decongestion. Okay?
Maybe these anxious parents, we can take some time to explain and
Yes,
reassure them as well, right, doctor?
true.
Yes. Okay. The next question is, do you give oseltamivir routinely for flu infection?
Right. If we suspect influenza, we do give. That's the only antiviral we have now. So we do, especially those who come with lower respiratory infection, we give them routinely, especially when they end up in pediatric ICU.
All right, doctor. Questions after questions are coming for you. We have 9 more questions to answer, doctor. I think after that we shall end our session. Is it okay?
Sure, no problem. I'm okay.
Okay. So, how to reassure parents that insist on wanting antibiotics?
Okay. It's difficult. It's difficult. If they are with us in the inpatient care in the hospital, it's much easier, right? But if I'm sitting in a say clinic base as a pediatrician, it's not easy to convince them. Unless they are your regular patients, much easier. So you try to explain as much as possible. Usually, if you explain in detail, many parents will accept. Many, not all. Especially if you're a regular patient, they usually trust you and not take it. But again, in the hospital, we don't start antibiotic immediately because we are still observing the child. But how do you expect a general practitioner or a pediatrician in private sector to monitor the child? It's difficult because now today can be a throat may look like a virus, but tomorrow may become very worse and turns out to be bacteria. So, but the general practitioner or the private pediatrician do not have access to their child every 8 hours like what we did in the hospital. So it's a very difficult decision. But generally, most general practitioner and pediatrician, they are generally quite careful with unnecessary antibiotic for children. So I would say that take the history and weigh the benefit and the benefit against losing the child with some severe throat infections. So just take some detailed history and try to convince them it's really not necessary. And sometimes what I tell them is that you talk to them. If they're not convinced, you tell them not to worry. So never mind. You come again tomorrow. Some of my fellow colleagues do that. They don't charge them for the next day. They just tell them, you go back, come back again in 24 hours. Let me examine your child again. And then the child usually tend to improve in 1, 2 days. Then the parents are convinced, oh, this doctor is correct. It was just virus. But if you look at it next day and it's significant, then you sort of charge for your medication and start your antibiotics. Yeah. Right.
Next question, doctor. If there are multiple viruses detected on respiratory panel tests, how to tell which one virus is causing the current illness or multiple causative viruses?
Yeah, this is a very good question, a very good observation by the person asking. Yeah, because those days we always have one virus coming out. Nowadays we see multiple viruses. Very often, even the hospital base, we see more than one. You see, only human beings are now getting along. Those days we were taught, but two viruses don't get along. When one virus enters the body, no other virus can enter your body because viruses don't get along. But nowadays they're getting along very well. So we tend to see metapneumovirus with influenza, adenovirus with influenza. So we tend to see it. But again, what medication do you have? The only thing we have at the moment is only oseltamivir. So it doesn't really make a difference what we give because the only thing we have is oseltamivir, and we just treat them. If virus, you just have to treat the secondary infection too. So otherwise, there's no major advantage of taking, except for a notification purposes. If it's influenza or, for example, turn out to be COVID for notification. Otherwise, even influenza is not a notifiable disease, if I'm not mistaken. So it doesn't make a big difference, treatment-wise.
Actually, influenza, they just take it for surveillance purpose, but not
Yeah, no notifiable disease, yeah.
Okay, doctor, next question. Any role of nebulized steroids, as example, Palmicort in groups?
Right. I do give. What I usually do is that when they give the initial dose of dexamethasone, I follow up with a Palmicort nebulization. It works.
Okay. Doctor, next question. In group, what are the roles of adrenaline or Palmicort? I think we have...
Mild to moderate group, I use Palmicort. Very severe ones, the one we use adrenaline.
Okay. The next question, doctor. How do we determine patient's symptoms fit with protracted bacterial bronchitis, and when do we decide for antibiotics?
Very good question. It's not uncommon to find someone who has recovered from the upper respiratory infection, and then the child continues to cough, and this is very brassy cough. So then you wonder, is there some form of bacterial bronchitis going on? So when they cough like as if it's main problem is the upper airway, and it's going on for some time, more than a week, then I usually treat with antibiotic, course of antibiotic. Often I give a trial of either augmentin or even clarithromycin. It works. It's a good practice to, if they continuously have it, after the initial recovery within 10 days, they continue to cough. Then I tend to treat with antibiotics.
Doctor, how about in primary care, when you, like, for example, if the child doesn't seek any treatment at tertiary center and they come to primary center with like prolonged cough for more than...
Oh, no harm giving a trial. These children are usually quite well. Not much of fever. They usually don't have fever at that time. Meaning that these are children who has recovered from a episode of upper respiratory infection, and then they continuous cough. They are otherwise well. So even in primary care, there's no rush to refer to them unless you suspect something else. You just give them a course of antibiotic, review them in 1 week's time.
All right.
Many of them will do well.
But because sometimes in primary care we have limitations in augmentin, so erythromycin is
Fine,
okay.
erythromycin is fine. You can give it a try.
Okay. All right, doctor. Thank you. Next question, doctor. What is your opinion on cough and flu patch for children below 1 year old? Does it really work?
I really don't have experience with this. Sorry.
First time hearing that is cough
Yeah,
and
truthfully, I'm first time.
flu.
I must read up.
Alright. I think boleh PM tepi kot, doctor.
Yeah.
Alright. Next question. Doctor, should we advise the parents who did not vaccinate their children to get those jabs as soon as possible once they have recovered from acute illness, if they recover?
Yes, certainly. You see, sometimes we do it opportunistically. Those who refuse vaccination, suddenly when the child is very unwell, then they freak out and say that, "Hey, yeah, my child is, because of this particular organism which is vaccine preventable, now my child is down with that particular disease." So opportunity, we'll try to vaccinate them as much as possible.
The next question. What is your opinion on giving salbutamol syrup to children more than 6 months old in GP settings?
Okay. I know this is not an uncommon practice in primary care or private practice. But generally, if you look at it, it's not advisable to give syrup. But of course, then what do we give? Some people say, okay, prescribe them methadose inhaler for a short period. But then they have to buy a spacer. So it's expensive. So sometimes general practitioners, and so if you look at a practical component of probably, so I won't say it's very, very dangerous, but it's not a standard practice.
Yeah,
So
our
if
last
someone is given, I don't criticize them. It's okay, as long as they give the proper dosing. Because for them to ask the patient to take salbutamol methadose inhaler, most young children cannot take it directly. They need a spacer. Spacer alone will cost about 70 to 80 ringgit. So it's tricky. It's tricky.
okay, doctor. Last question of the day. I noticed many GP prescribing oral steroids for URTI. Is it advisable?
Yeah, I'm not aware that they are prescribing, but certainly should never ever prescribe steroid for upper respiratory infection.
So I hope that this question and answer session has answered all your doubts. So we would like to extend our gratitude to all our attendees for actively participating in today's MMA Kedas Pediatric series webinar focusing on upper acute respiratory infections in children with Dr. Tiaga. I would like to take this opportunity to thank Dr. Tiaga for spending his time with this educational webinar. We trust that you found the session both enlightening and informative. So please stay connected with us for further events and discussions. Do follow us in our Instagram account MMA Kedah or MMA Kedah Facebook account where will keep on posting our updates on webinars or other activities that we will be conducting in near future. Your engagement is greatly appreciated. Wishing you a pleasant evening and a delightful weekend ahead. Please hold on. We will take a group photo. Doctor, is it okay?
Sure.
Mr. Dana,
Yes, Sir.
can we take a group photo? I mean, screenshot.
Yeah, can.
Okay. Okay, go.
One, two, three. Okay, done, Doctor.
Okay, thank you, Mr. Dana.
Okay, welcome, Doctor. Bye.
QR code
Thank you.
we will send it by manual, right?
Yeah, I will giving the data to Anu Surya, so she will upload the attendance in the system.
Okay, so our MMA CPD point will be submitted manually to
Yeah,
MMA you, and it will be updated into our CPD account. Okay,
yeah,
thank
correct, correct.
you, everyone. Thank you, Mr.
Dr. Danu, there's someone asking whether there be recording available for them.
Later I can get it from Mr. Dana, and I'll
Okay,
post it in MMA Kedah.
okay, all right.